So, a disorder related to the height of the child and upper segment lower segment ratio is short stature. Now let us see what is the definition of short stature, what are the types of short stature, important causes of short stature, and some details about some of the causes. Okay. So first the definition. So short stature is defined as length or height of a child less than third percentile or less than -2 standard deviations of expected according to the age and sex of the child. Right? So short stature is height of a child or length of a child less than third percentile or less than -2 standard deviations of expected according to the age and sex of the child. So let us see what that means. So if we try to plot it on a growth chart, okay, so you may be given a growth chart in exam and you may be given a child and his height and weight and you may be asked to plot it on the growth chart and interpret the same. Okay. So if this is the age of the child, this is the height of the child, say, just for example, 1 year, 2 years, 3 years, 4 years, and so on. So you can use a 5-year wala or 18 years, whatever is the age of the child. 50 centimeters, 100 centimeters, 150 centimeters, and so on. Okay, and you have lines like this: 50th percentile, third percentile, okay, 97th percentile, or you can use the standard deviation wala growth chart, okay. And if it is a boy, you use growth chart for boys. If it is a girl, you use the growth chart for girls, okay. Now, for example, if the height of a child at 4 years is say only 75 centimeters or 80 centimeters, it lies somewhat here. Okay, 75 centimeters suppose at 4 years. So it is less than third percentile of expected according to the age of the child. Okay, and if it is a boy, you are using the growth chart for the boy. So this child has short stature. Okay, so if the height of the child lies anywhere below this third percentile line or below the -2 standard deviation on a standard deviation chart, then that child has short stature. Okay, so that is what we mean by this definition. Now coming to the classification, what are the important types of short stature? The classification. There are two important types of short stature. They are proportionate short stature, and disproportionate short stature. So in proportionate short stature, both the trunk and the limbs are proportionately short. Now the trunk or the vertebral column mainly comprises the upper segment, while the limbs, especially the lower limbs, comprise the lower segment, right? So if both the trunk and the limbs are proportionately short, then both the upper segment also reduces, lower segment also proportionately reduces. So what will happen to the upper segment is to lower segment ratio? It remains normal or unchanged. So in all the causes of proportionate short stature, the upper segment is to lower segment ratio remains normal or unchanged. Okay. While in disproportionate short stature, this ratio is going to change. How it will change, we will come to it when we discuss the causes of disproportionate short stature. Okay. So now moving on to some important causes of proportionate short stature. So important causes of proportionate short stature. So in order to make it easy to remember, we can classify the important causes of proportionate short stature into three categories. One is normal variants. Another category is intrauterine causes. And a third category is postnatal or acquired causes. So postnatal or acquired causes. Okay. So normal variants includes two categories. One is called familial short stature. So the normal variants include familial short stature, and something known as CDGP, that is constitutional delay in growth and puberty. CDGP. CDGP means constitutional delay in growth and puberty. Constitutional delay in growth and puberty. Okay. CDGP, constitutional delay in growth and puberty. Right? So let us first discuss a little bit about familial short stature and constitutional delay in growth and puberty before moving on to the other causes of proportionate short stature. Okay. So we need to know from a given case scenario whether it is familial short stature or CDGP, what are the salient features of these, how do you distinguish them, and we need to understand why we are calling them normal variants. Okay. So first a little bit about familial short stature and CDGP. So familial short stature versus CDGP, constitutional delay in growth and puberty. So familial short stature, the name itself is telling you, in a family, if both the parents are short, then obviously that child is also expected to be short. So if you plot the height of the child on a growth chart, it will be less than what is expected for him. Okay, it will be less than the third percentile. But if you look at the height of that child according to the height of his parents, okay, as per his target height, his height is normal. So that is why it is a normal variant. Okay. So let's write down. So familial short stature means that the child's height is less than third percentile or less than minus 2 standard deviations of expected according to the age and sex, of child, but it is normal as per his target height. Okay, it is normal as per his target height. Okay. What do you mean by this target height? So, based on the height of the parents, you can calculate something known as mid-parental height. Okay. So, we need to know the formula of mid-parental height. It may be sometimes asked for you in the MCQs. So, what do you mean by mid-parental height? Let us see. So, the mid-parental height it is separate for boys and girls. Okay. So, mid-parental height for boys is father's height plus mother's height plus 13 by 2 centimeters. While for girls, it is father's height plus mother's height minus 13 by 2. So that is how you calculate the mid-parental height based on the height of the parents. Okay. Now, how do you get the target height? So just to give you an example to understand this concept. Okay. So, if say it is a growth chart, where you have the height and you have the age in years, height in centimeters, of course. So you have say 2 years, 4 years, 6 years, 8 years and so on. You have it till 18 years or 20 years of age. Okay. So let us have some idea about this familial short stature. So we said that the child's height is less than what is expected according to his age and sex, but it is normal as per his target height based on the height of his parents. So the target height is based on the mid-parental height. So this is the formula for the mid-parental height. So just to give you an example, suppose the mid-parental height of a child, you calculate it and it is coming to around 120 centimeters, just for an example, hypothetical. Okay. So it is falling here. If you plot it at 18 years of age, so 120 centimeters. From 18 years of age, it will fall here, right? So, your target height would be around, the target height is usually taken as around 8.5 centimeters on either side of the mid-parental height. So, from here to here would be the target height for the child, okay? So, if the child's height lies anywhere in this target height zone, so if the child's height is lying anywhere in this zone, then we take it to be normal as per the height of his parents. Okay. So, if the child's height is say lying here, okay. So, even though you can see it is less than the third percentile, this is the third percentile line, right? So, even though it is less than the third percentile, it is normal as per his target height. This is his target height, okay? Based on the height of his parents. So, it is normal as per his target height. Then this child has familial short stature. Okay, familial short stature. So, child's height you can see is less than what is expected according to his age and sex, but it is normal as per his target height based on the height of his parents, right? So, that is familial short stature. Okay. Now, coming back to familial short stature versus CDGP. So, familial short stature, we said that the child's height is less than third percentile of expected according to age and sex, but it is normal as per his target's height. What about CDGP? So, in CDGP, what happens? So, the full form of CDGP is constitutional delay in growth and puberty. So, the key word here is delay. So, there is a delay in the growth of the child. So, at 6 years, if you look at the height of a child, it can be that of a 4-year-old. At 8 years, if you look at the height of a child, it will be that of a 2 years old. Okay. So, there is a delay in the height, right? So, if at 6 years of age, you look at the height of the child, it will be that of a 4-year. At 8 years of age, it will be that of a 6-year. Okay. At 10 years of age, it will be that of a 8-year-old child. So, there is a delay. But the ultimate final height attained is going to be normal. So that is CDGP. There is a constitutional delay in growth and puberty. So child's height is less than expected during childhood, but the final adult height attained is normal. Okay. Final adult height attained is normal. So child will catch up that height during puberty. Attained is normal. Okay. So at different points during childhood, if you see, his height is less than what is expected for that age. But the final adult height attained is normal. Okay. So if we plot it on our graph here, okay, in CDGP what will happen? At different points during childhood, if you see, the child's height will remain like this, below the expected. So it will be almost parallel to the growth chart, but the ultimate final height attained will be normal. Okay, the final height attained will be normal like this. So this is CDGP. So constitutional delay in growth and puberty. So now you can make out why we are calling it a normal variant, because the ultimate final height attained is going to be normal. Though during childhood, if you see, child's height is less than what is expected. Okay. So now from a given case scenario, how do you distinguish whether it is CDGP or familial short stature? So in familial short stature, the child has normal puberty, no problem with the puberty of child. Okay. So child has normal puberty. While what happens in CDGP? The child has delayed puberty. The name itself is telling you constitutional delay in growth and puberty. Okay. So the child has delayed puberty. Okay. In familial short stature, you will get a family history of short stature. Both the parents are also short. Okay. So family history of short stature. But in CDGP, the parents have normal height. But if you probe and take history from them, you will find that there might be a history of delayed puberty in the parents also when they were young. Okay. So history of delayed puberty in parents, you may get it. So family history of delayed puberty as well. Right. Another very important point, if you look at the bone age. So you can get an idea about the ossification status. You can get an idea about the age of the child by doing certain x-rays and looking at the ossification of various bones. That is called bone age. So normally in an individual, the bone age should correspond to the chronological age. Chronological age means the age derived from the date of birth. Okay. So in familial short stature, the bone age is equal to the chronological age. Okay. While in CDGP, there is a constitutional delay in growth and puberty. So there is a delay in the ossification of bones also. So in CDGP, if you do the X-ray, you will see that the bone age is less than the chronological age. So bone age is less than the age based on the date of birth. Okay. So in CDGP, the bone age is less than the chronological age. Right. So this is how from a given case scenario you can distinguish whether it is familial short stature or CDGP. But both are normal variants, but they are different from each other. Now a little bit about bone age, you get questions from that. So bone age, we need to know what X-ray is recommended to do the bone age at different age groups. Okay. So for doing bone age in neonates, you can look at the X-ray of knees. Okay, because the ossification center around knees appear near the time of term. Okay, so X-ray knee you can do. In infants, especially between 3 to 9 months of age, X-ray shoulder is very useful. Okay, X-ray shoulder between 3 to 9 months of age. While in children between 1 to 13 years of age, the X-ray of hand and wrist. Conventionally, it is the left side which is preferred. Okay, so X-ray left hand and wrist is used to get an idea about the bone age of a child. So these are the various X-rays that you use at different time points to know the bone age of a child. Now, bone age is less than the chronological age here. In certain other scenarios also, you can get bone age less than the chronological age. So, what are the conditions where you can get bone age less than the chronological age? Let us see. So, one we said is CDGP, you get bone age less than the chronological age. You can get bone age less than the chronological age in congenital hypothyroidism also. You can get it in growth hormone deficiency. Okay, and severe malnutrition also you can get bone age less than the chronological age. So these are some very important informations that we need to know about the bone age, right, and about familial short stature and CDGP. So just to recapitulate, so familial short stature in the both the parents are also short, so the child is also short. So child's height is normal as per the target height. While CDGP, the child's height is less than expected, but the final adult height attained is normal. Familial short stature, no problem with puberty, normal puberty. CDGP, delayed puberty. Familial short stature, family history of short stature. CDGP, family history of delayed puberty. Then familial short stature, bone age is equal to chronological age. CDGP, bone age is less than chronological age. And we saw certain other situations where the bone age is less than chronological age and the important X-rays used to do the bone age, right? Now coming back to our list of important causes of proportionate short stature, okay? But before that, let us mention one more thing, that this CDGP is the most common cause of short stature during childhood, okay? So the CDGP is the most common cause of short stature during childhood. So most common cause of short stature during childhood. Okay. Now, intrauterine causes of proportionate short stature include IUGR. What is the full form of IUGR? Intrauterine growth restriction, not retardation. Okay. IUGR, then intrauterine infections, especially by the TORCH group of organisms. What do you mean by TORCH? Toxoplasma, rubella, CMV, herpes, others, okay, like syphilis. And genetic syndromes. So genetic syndromes like Turner syndrome, Down syndrome, Seckel syndrome is another genetic syndrome where you can get proportionate short stature. So Seckel syndrome is something known as bird-headed dwarfism. So where the face of the child resembles that of a bird. So you will get an elongated face, beak-like nose. Okay, Seckel syndrome, also called bird-headed dwarfism. So I'll show you a picture of a child with Seckel syndrome later so that you can identify it, a very important spotter. So bird-headed dwarfism or Seckel syndrome. And of course, we'll be discussing about Turner syndrome and Down syndrome in the genetics section. Now coming to some postnatal or acquired causes. So postnatal or acquired causes include severe long-standing malnutrition. Severe long standing. So, the malnutrition has to be long standing or chronic in order to give rise to short stature. Okay, so severe long standing malnutrition. Any chronic systemic illness. Any chronic systemic illness like CKD, chronic kidney disease. Okay, like chronic kidney disease. Right? Then malnutrition. Any malnutrition syndrome like celiac disease, where there is a sensitivity to gluten. Okay, celiac disease. Then there can be some endocrine causes or hormone related causes like growth hormone deficiency. So remember, growth hormone deficiency is a very important cause of proportionate short stature. Cushing syndrome during childhood can also give rise to it. Okay. There is also something known as psychosocial dwarfism. Psychosocial dwarfism, which is basically due to maternal deprivation. So, if the child does not get the tender, loving care of the mother, then also it can give rise to short stature in the child. So, psychosocial causes like maternal deprivation. Okay. Now, a little bit about growth hormone deficiency here. So, some important MCQs that we need to remember about growth hormone deficiency are. So, one is, in growth hormone deficiency, we already mentioned because growth hormone deficiency is a cause of proportionate short stature. So, the upper segment is to lower segment ratio remains normal in growth hormone deficiency, right? Apart from that, bone age is less than the chronological age in growth hormone deficiency. And because growth hormone does not have a continuous secretion, okay, it is released in spurts. So, a single estimation of the growth hormone level might not give us a true idea whether growth hormone deficiency is present or not. So, we need to do dynamic testing. Dynamic testing is required for growth hormone deficiency. So, we do growth hormone stimulation test, okay. So, growth hormone stimulation test can be done using clonidine or arginine or insulin. Any of these can be used to do growth hormone stimulation test, right? Now, the treatment, if there is growth hormone deficiency, recombinant growth hormone therapy is available. So, injection growth hormone has to be given subcutaneously almost daily or 5 days a week it may be given. And one important side effect of growth hormone therapy is pseudotumor cerebri, which is sometimes asked in MCQs. So, growth hormone deficiency, a very important cause of proportionate short stature. So, important causes of proportionate short stature we classified into 3 groups. So, one group is normal variants, okay. Another group is the intrauterine causes, which includes IUGR, intrauterine infections and genetic syndromes. And the third group is postnatal or acquired causes, which includes severe long-standing malnutrition, any chronic systemic illness, then malabsorption or celiac disease, endocrine causes like growth hormone deficiency, Cushing syndrome, and psychosocial causes like maternal dwarfism. Okay. So, it is malabsorption. Malabsorption as seen in celiac disease, right? And we saw some important points about growth hormone deficiency and about Cushing syndrome. One very, very important point is the most common cause of Cushing syndrome is iatrogenic. So, it is exogenous administration of steroids which is the most common cause of Cushing syndrome in children. So, these are the things that we need to know about proportionate short stature. So, now moving on to some important causes of disproportionate short stature. So, important causes of disproportionate short stature. Disproportionate short stature can be classified into either short trunk dwarfism, where the trunk is disproportionately short but the limbs are normal, while on the other hand, it can be short limb dwarfism, where the limbs are disproportionately short and the trunk is more or less normal. Okay. So, two main groups in which we can classify it. So, they are the short trunk dwarfism and short limb dwarfism, where the limbs are disproportionately short as compared to the trunk. Right? Some important causes of short trunk dwarfism. But before that, can you imagine what will happen to the upper segment is to lower segment ratio in short trunk dwarfism? So let us see. The upper segment is to lower segment ratio. So what is happening in short trunk dwarfism is the trunk is short. So the upper segment is decreasing or the numerator is decreasing. So the ratio will decrease. Okay. So upper segment is to lower segment ratio decreases in all the causes of short trunk dwarfism. While what happens in short limb dwarfism? So in short limb dwarfism, the limbs are mainly short. So the lower segment is decreasing. The denominator is decreasing. So the ratio will increase. So upper segment is to lower segment ratio increases in all the causes of short limb dwarfism. Right? And we can understand now why. Okay. Now moving on to some important causes of short trunk dwarfism. So let us see some important causes of short trunk dwarfism are. So there is something known as spondyloepiphyseal dysplasia. Okay. Spondyloepiphyseal dysplasia. So though the name sounds to be very complicated, but remember, if there is a spondylo in the name, that means the spine is most commonly affected. Okay. So because the spine or the vertebral column is most commonly affected here or more affected here, so the upper segment is mainly involved because the vertebrae are involved. So it is a cause of short trunk dwarfism. So causes of short trunk dwarfism are the conditions where predominantly the vertebral column is involved. We will get short trunk dwarfism. Okay. So they are spondyloepiphyseal dysplasia, spondylo meaning spine. Then there is a metabolic disorder called mucopolysaccharidosis. Okay. A similar condition as compared to mucopolysaccharidosis is mucolipidosis. That is also a lysosomal storage disorder where mainly you get bony changes in the spine. Okay. Then if the child has Cary's spine or TB spine or Pott's disease, okay, Cary's spine or Pott's disease or TB spine, then you can get short trunk dwarfism. Okay. Similarly, if the child has hemivertebra or butterfly vertebra, okay, hemivertebra or butterfly vertebra, so any congenital vertebral defect can give rise to short trunk dwarfism. This butterfly vertebra is seen in a condition called Ala-Gille syndrome. It may be asked in MCQs for you. So, Ala-Gille syndrome. So, in Ala-Gille syndrome, what all do we get? So, we get butterfly vertebra, then we can get cholestasis, neonatal cholestasis. So, it is one of the causes of conjugated jaundice in newborn or infancy. Okay. So, you can get neonatal cholestasis. or conjugated jaundice. There can be facial dysmorphism or triangular faces. The face is triangular in shape in Alagille syndrome. Okay. Triangular faces can be there. And there are presence of some heart defects like pulmonary stenosis. Okay. This triangular facies is also seen in another disorder which has been asked in the MCQs previously. So, this triangular facies is also seen in Russell-Silver syndrome, another syndrome where you can get triangular facies. Russell-Silver syndrome has been asked in the NEET pattern previously. Okay. So, in which of the following syndromes you get a triangular facies? The answer is Russell-Silver syndrome, or in the presence of conjugated jaundice and vertebral defects, it is Alagille syndrome. So, these are some important causes of short trunk dwarfism, which we can remember by a mnemonic. So, let us see what the mnemonic for short trunk dwarfism is. So, it is short man may climb high. Short man may climb high. So, you should never underestimate anyone, including yourself. So, short man may climb high is the mnemonic here, and let us see how it works here. So, with S, you have spondyloepiphyseal dysplasia. With M, mucopolysaccharidosis. Another M, mucolipidosis. Okay. With C, Carey's spine. With H, hemivertebra or any congenital vertebral defect. So, that is the mnemonic here. Short man may climb high. So, these are some important causes of short trunk dwarfism. Now, moving on to some important causes of short limb dwarfism. Okay. So, short limb dwarfism where the limbs are predominantly affected, okay, as compared to the trunk. So, this includes causes like rickets. Another important entity is achondroplasia. Okay. Another condition where you get it is osteogenesis imperfecta. Congenital hypothyroidism also you can get short limb dwarfism. And conditions like chondroectodermal dysplasia. So, chondro means cartilage. So, it is mainly the long bones, the cartilages, epiphyseal cartilages at the ends of long bones, okay, which is involved. So, mainly that is involved. So, chondroectodermal dysplasia. So, if spondylo is there in the name, it is mainly short trunk dwarfism. If chondro is there in the name, it is predominantly short limb dwarfism. So, these are some important causes of short limb dwarfism, okay, where the limbs are predominantly affected, okay. So, about rickets, we will be discussing in detail in the chapter on musculoskeletal system. You can refer that chapter for details on rickets, a very important disorder indeed. A little bit about achondroplasia I will tell you here. So, achondroplasia is a classical example of what kind of inheritance? I am sure all of you know it. Yes, it is autosomal dominant inheritance. Very, very important. One of the questions on which no mistake is pardonable. Achondroplasia is an example of autosomal dominant inheritance. Okay. So, let us see some important features of achondroplasia which are important for our MCQs. So, achondroplasia, as we mentioned, is a classical example of autosomal dominant inheritance. Right. Very, very important. A direct question has come multiple times. Okay. Now, some important features of achondroplasia which are important for MCQs, let us see. So if you do a X-ray pelvis in a child with achondroplasia, we get something known as champagne glass pelvis. Okay. Right. There is a hand abnormality that you get in children with achondroplasia that is called trident hand. So hand abnormality called the trident hand. Okay, very important. So the hands appear like this. The fingers are oblique to each other. It is called trident hand. Okay. Then you get obesity. These individuals are obese. There are some neurological problems in them. Okay. There can be some neurological problems. Delayed motor milestones is common in them. Okay. It is such a severe disorder that it is usually recognized at birth. Recognized at birth even. Okay. Apart from that, you can get bowing of legs. There is shortening of the limbs, right? But it is mainly the proximal part of limbs that is shortened. So proximal limb shortening. These individuals have got a large head. Short stature is there in them, of course. Short stature with short limbs. So, if you have seen circuses which used to be there previously, the clowns in the circuses are usually, the individuals with achondroplasia, those who come as dwarfs. Okay. So, short stature. And interpedicular distance between the vertebra decreases. So, normally as you go downwards in the lumbar region, the interpedicular distance between the vertebra should increase. But in achondroplasia, you can get interpedicular distance between vertebra decreases. Between vertebra decreases. So these important features of achondroplasia you can remember by the mnemonic achondroplasia itself. Let us see how. So achondroplasia, the C. So remember, nothing is there with the A's except the autosomal dominant inheritance. But with all the other alphabets in the word achondroplasia, you have some clinical feature or some important finding. So with C, we have champagne glass pelvis. So C for champagne glass pelvis. H for hand abnormality. O is for obesity. N for neurological problems. D is for delayed motor milestones. R recognized at birth. Another O is the O in bowing of legs. Okay. P proximal limb shortening. L for large head. S for short stature. And I for the interpedicular distance between the vertebra decreases. So these are the important features of achondroplasia which we can remember by the word achondroplasia itself. It has got autosomal dominant inheritance, and what is the gene involved in achondroplasia, which can be a potential question for you. So the gene involved in achondroplasia is the FGFR3 gene. The fibroblast growth factor receptor gene is involved in achondroplasia. Okay. So that is about achondroplasia, a very important cause of short limb dwarfism. Okay. So coming to important cause of short limb dwarfism, we discussed about rickets. We can see in the musculoskeletal system, achondroplasia. We already discussed some important features. A little bit about osteogenesis imperfecta here. So osteogenesis imperfecta, you get a classical triad of recurrent fractures or bony deformities. Because of the recurrent fracture, their malunion, there will be bony deformities. So, recurrent fractures or bony deformities. Blue sclera. So, you know the white part of the eye is blue in them. So, you get a blue sclera. Okay, recurrent fractures, blue sclera and deafness. So, that is the classical triad that you get in osteogenesis imperfecta. Now, here in osteogenesis imperfecta, the bones are so fragile that, you know, if you have ever seen someone doing sampling or putting IV cannula for a child, you will see that you have to hold the limbs really tight because the child will keep on moving. You cannot do the sampling or put a cannula. So, just when you are holding the limb for cannula, for putting a cannula or for doing sampling in the child with osteogenesis imperfecta, the bones can fracture. So, the bones are so fragile, they fracture very, very easily. So, it is also called brittle bone disease, okay, and it is basically a defect in the type 1 collagen. So, there is a type 1 collagen defect. And it is called the brittle bone disease, okay. Now, these children can also have some dental enamel problems, that is called dentinogerous imperfecta. So, teeth involvement can be there. It is called dentinogerous imperfecta. And for the treatment of these children, bisphosphonates have been seen to be useful in treatment. They decrease the risk of fracture. So, bisphosphonates like pamidonate are useful in the treatment. So, that is about osteogenesis imperfecta. Okay, a very important spotter you can get if you are getting a child with multiple bony deformities and blue sclera, think of osteogenesis imperfecta. So, these are some important causes of disproportionate short stature. So, we saw some important causes of short trunk dwarfism where the trunk is mainly affected, and some important causes of short limb dwarfism where the limbs are mainly affected. Okay. So, that is about short stature. So, we saw the definition of short stature, we saw the two important types of short stature, that is proportionate and disproportionate. We saw some important causes of proportionate short stature, some important causes of disproportionate short stature, and some important findings or some important points that we need to remember about some of the causes for our MCQs.